Top Med Talk.
Hello and welcome to Top Med Talk. Today's Top Med Talk features a panel discussion chaired by Denny Levett, Professor in Perioperative Medicine and Critical Care at the University of Southampton and a consultant in Perioperative Medicine at Southampton University Hospital, NHS Foundation Trust. And it features Andrew Davies, consultant in upper gastro-intestinal surgery at Guy's and St Thomas's. Also, Heather Gill, a vascular surgeon at McGill University and research chair for the Canadian Society of Vascular Surgery. Gerry Danjoux, consultant in Anaesthesia and Sleep Medicine at the South Tees Hospital's NHS Trust. And Chelsia Gillis, assistant professor in the School of Human Nutrition and the Faculty of Agricultural and Environmental Sciences at McGill University. Also, Liam Humphreys, senior research fellow and lead of the Living Well with Chronic Disease research theme at the Advanced Wellbeing Research Centre. This panel discussion comes off the back of a series of presentations, all of which are available on Top Med Talk and can be found in the show notes to this podcast.
So some questions from the audience. For Andrew, has any work been done on how to communicate risks and benefits of delaying treatment to patients to support shared decision-making conversations?
No, not specifically in relation to that question. It's not really common practice, partly because the intervention is, relatively speaking, within its infancy. Certainly in my field, in OG, we don't do a lot of primary surgery. So probably I can dodge that question by saying it doesn't happen to us very often. And maybe other surgical specialties where surgery up front is used a lot might be better placed to answer. But I would say that every time we try and analyse shared decision-making and patient views, we are generally quite surprised. In OG in Rotterdam, they conducted a discrete choice experiment on patient views of their further treatment after definitive chemoradiotherapy, and the clinicians all expected that patients would not accept any compromise in survival in order to favour their quality of life. But actually, very clearly, patients were prepared to accept about a 15 to 20% reduction in survival in order to maintain health-related quality of life. So if you were to extrapolate that principle into that question, if we were to categorically say that we could prove that 6 weeks of prehabilitation was beneficial compared to 2 weeks, and if we were then to take that to our patient group and explain those differences, I suspect that most of the clinicians would be anxious about the cancer-related outcomes, and I suspect that most of the patients would actually, potentially, some of them might favour that intervention if it were to offer them better quality of life and other metrics that cancer specialists less frequently talk about.
Yeah, thanks, Sandra. I think that's true. I think we should all think about the fact that often what patient thinks are fates worse than death are not what we think are. We often think death is the worst outcome. So that, Heather, you want to add something?
Hi, my name's Heather Gill. I'm a vascular surgeon from Montreal. Just to add to that, which is very different from the cancer, but in the time of COVID, I don't know the literature for all the different cancers, but I know a lot of surgical societies had to put out guidelines or expert consensus on the longest that patients could wait because of restrictions. So it's actually both the American Vascular Societies, the British Vascular Society, the European Vascular Society all came out with consensus statements on safe waiting times for different surgeries. So for instance, an aneurysm of a certain size, it was safe to wait 8 weeks, or the consensus statements. So when we're talking about delays to surgery, I think those might be out there in the literature already and could be very interesting for your discussion with your patient. I know we are using it for our aneurysm trial. We have 3 different consensus guidelines saying that it is safe to wait 6 weeks or 8 weeks for your aneurysm to be repaired. So that's been super beneficial to us.
It's really helpful, yeah.
On the same topic, I think is also the way how we approach the problem that perhaps we could change. I want to be really provocative now, and I want to do a little experiments. And here, I would like to ask you if you could raise your hand if you have 1 week before, for example, an esophagectomy, a patient who develops pneumonia, who is a modifiable risk factor. So how many of you would delay surgery for treatment? Okay. So I don't think anyone operated someone with an elective procedure with pneumonia, so we don't know mortality and complication associated with that. But for example, if we have a severely malnourished patient who is also modifiable risk factors, who is associated with increased mortality and complications, how many of us in reality would delay surgery to try to modify these risk factors and postpone surgery. Well, there's a selection bias here, but but we know in reality that it's not always like that. So I think it's our way how we translate the message to our patients on the importance of trying to modify these risk factors, because we know, and a recent trial published, I think last year on BGA, reinforced the message that we know that complications, of course, after surgery are associated with increased risk of mortality. If we're talking about just mortality, and also cancer survival. So it's a difficult call, but I think knowing in advance who might respond to prehab would better facilitate our decisions in when to postpone and when not.
I think one of the other important things, as Andy alluded to, is that before you think about delaying, we should be exploiting the whole pathway. Because I think it's the easy thing to do to delay surgery because you've only found out about them just before the operation. But every time we looked, even patients we'd only just found out about, they'd actually been known to the trust for between 4 and 6 weeks. A lot of the time it shouldn't be necessary. Gerry, any thoughts?
I see this actually in my other life as a sleep clinician in patients who have newly diagnosed sleep apnea.
Yeah.
You know, there isn't a huge amount of evidence out there about delaying surgery for sleep apnea, you know, in, say, mild, bordering on moderate severity. Yet, we get a huge number of referrals and patients are just cancelled from pre-op at short notice. That decision is made. And when you have those conversations, when I do it through the sleep clinic and I diagnose patients and they tell me, look, I'm waiting to have the surgery, I've been waiting for ages. Yes, it's not life-threatening. I think the conversation has to be housed around the severity, the type of operation they're having. And, you know, if they stop breathing and desaturate 100 times an hour, then the likelihood is if they're having an intra-abdominal procedure, they are going to run into problems. And in that situation, if you have conversation around what the risks are and, you know, how long they'll have to wait, the vast majority of patients I deal with are very amenable to waiting because they understand the modifiable element of the risk. And I don't think that's anything different, it's just a different context. And I think it's all around the way that the risk and the benefit is transmitted to the patient in the conversation. And if you're honest with them and you have a sensible conversation that they understand, I think they will help you with that decision. Is my reflection on that.
Yeah, I would agree. So a question I could put to you, Chelsia, what is missing in the established reporting guidance, i.e. the consult or the tidier, that indicates that we need one specifically for prehab? So what don't they have in them that's useful?
Well, one, they don't even have a nutrition one. So there's no nutrition reporting guideline available unless you're doing observational studies, epidemiology type nutrition studies. So there isn't a nutrition intervention. And these are fairly large checklists. So if you have a multimodal intervention and you need to add 4 checklists, it can add up. So we want to have a minimum set for prehab and develop one for nutrition in general.
I work very closely with the HPB team down in Plymouth. I'm part of their regular MDT meeting. We know patients are coming through early and we've really streamlined the pathway. But frequently the Whipple's patients have had obstructive jaundice. They are really deconditioned. They've had the effect of jaundice on the mitochondria. And we frequently will pause and get them active and get them improving once they've had the stent inserted, because we know that when we've tested them early how bad their CPET tests are, and if you give them even just 2 weeks, they bounce back reasonably quickly, and the patients themselves are very aware about how dreadful they feel and how they can barely get out of bed in the morning and go up and down the stairs. And then you see them 2 weeks later and see the improvement. So I think a lot of this feeds back into the discussion with the patient, with the surgeon, so we're all aware of what's going on and we can optimize in a short period of time and effectively improve a very obvious modifiable risk factor for those patients.
Thank you. Agree. So some questions about other outcome measures. What are the panel's thoughts on days alive and out of hospital at 90 days as an outcome measure of post-op morbidity? Shall I start with you, Gerry? What do you think?
It's not a measure that we used routinely as yet in any of our studies, but it seems to be a very sensible measure to use. It kind of starts to move us beyond this obsession with 30 days that internationally we do still seem to be obsessed with. And it also, I would have to defer to other experts here as to what actually that questionnaire captures functionally in days alive at home, rather than are you alive or dead at home at 90 days. But 3 months or 90 days does seem like a logical time frame, and to be in your own environment, if that's actually what it captures.
Yeah. It's sort of a mixture of morbidity and mortality. So it combines both. The problem with elective mortality is very rare, isn't it? Whereas it's are you out of hospital is an important question, because patients tell you that they want to get home and back to their quality of life. So if they're still in hospital, then they're not.
You speak to a patient about this, they're not really that interested about what they're going to be like in 30 days. They're kind of quite interested in 1 or 2 years' time what they're going to be like as well. So there is a longer term conversation that they're also interested in.
I'd agree. Heather, did you want to ask something?
Just as a surgeon in the room, most patients are followed up at around 4 weeks, hence the 30 days. It's a very easy target for surgeons in their clinical pathways as to when they see the patients. They don't usually see them at 3 months. Patients want to see you before, for sure, post-operatively, and you want to see them. So I don't actually know much about the questionnaire, and I know 30 days is not necessarily the best endpoint, but it does make a lot of sense in terms of when you're seeing your patients post-op and collecting the data. And
so, but I think, but that's something that perhaps we all should be thinking a little bit more about being a bit more patient-centred. In the UK, for example, we're being actively discouraged from following up patients unnecessarily and getting them to come back to hospital, because this idea that everyone needs to be seen routinely 6 weeks or 4 weeks post-op, just because of pressures in the system, unless there's a reason, you don't necessarily have to see them all. And patients, as Gerry said, if you're having an operation to prevent an event that may not have happened within 30 days, perhaps how you are at a year or even 2 years is more important. But I think as part of the outcomes consensus involving patients in which outcomes are important is actually really important, because on the whole we tend to measure things that are easy to measure. Bernard, do you want to go first?
The days at home, what makes it a beautiful metric is it captures the length of stay in hospital as well as readmission rate. So it's very patient-centric and captures both of those. But the question I really wanted to ask in the proposal is, when you consider capturing outcomes, and what you don't hear a lot of in the lectures to date is what patients are not responding to prehab. And because that's important to the surgeon, it's important to the patient, is if I could delay my surgery, but I'm not going to respond, I'm probably at risk of suffering harm from cancer progression, etc. So when we capture outcomes, I think we need to look at that data set of who's not responding, because that's an important information for deciding who should go on prehab and who shouldn't.
I agree, and that should be something we should think about within the consensus. So a non-responder rate, and whether it's a non-response or just a longer response, which is another controversial area. Sandy
Jackson from Southampton. Just on the days alive at home, I think it's worth noting that it has been previously recommended by large consensus groups. So the STEP Compact group has certainly recommended days alive at home for perioperative medicine studies. And one of the theoretical advantages of it is that if you have access to good quality data, so for example, if you have ready access to, in the UK, we've got hospital episode statistics, you can calculate days live at home for a large number of patients without having to burden the patients with a questionnaire at 30 days, at 90 days. You can generate it from your hospital episode statistics. I know that's not possible in all healthcare systems, and NHS Digital don't make it easy to get, but that's something we should be pushing for. It is a good pragmatic measure.
I think that's really true, because as we've all alluded to, no one's going to pay someone just to collect outcome data because of constraints of funding.
Hi, Denny. It's Rachel Barlow from Cardiff. We've been looking at days at home, 30 and 90. It's really hard to collect, even with, hospital, you call it HES, we call it PEDU in Wales, because of the social, because also it takes into account going into a nursing home, convalescent home, whatever you want to call it. It's really, really hard. I agree with you, Sandy. It's absolutely the gold standard, but in practice, it's really hard to do without good data linkage across social care, healthcare.
Interesting point. Richard Struthers from Plymouth has said, in the UK we have a programme called PQIP, which is a post-operative quality improvement programme, which collects longer-term outcome data. Would we benefit from aligning to existing data sets to reduce the burden of collecting more data, I guess.
I think a few people earlier in the talks, rather than defining these things as ERAS or prehab or survivorship, talked about a continuum of care. And that absolutely is a theme. Data collection is a problem in the field of survivorship, just as it is in the field of enhanced recovery and prehabilitation. So one of the continuous frustrations at a unit level is being asked to manually input data into multiple platforms. It absolutely cripples us in terms of our resources to move things forward. So in terms of how we make that more automated and how all of these sort of systems of data capture, talk to each other is hugely important moving forward. Every unit is just asked for more and more and more data. We all believe in the merits of providing that data and the projects that they're supporting, but it takes a huge amount of time.
Yeah, and I think that's right. And clinicians aren't necessarily always the right people to be entering all of that data. I'm sure you've got better things to do with your expertise. I think that's about a conversation of having the right support for us to be able to enter accurate data. But it's absolutely crucial that the systems talk to each other, because if you've got garbage in, you're going to get garbage out, and then everybody's going to be misled in their practices. So there is a conversation to be had around that, definitely. I'd be interested in the settings other than the UK, what the data collection systems are like and how they talk to each other. Are they better? I don't know. Are they better?
Gabriel?
Spain?
On Italy?
As far as I know, I'm back only since a year and a half. There's no national registry where we can put together, or if there is, there are only for certain disease or cancer, perhaps registry, but not perioperative, such as the NESQIP or something like you have here. Yeah. I think it's important to have it, but it's also, as mentioned just now, it's important to have resources for put the data in to make sure that what the data we put in are accurate. Don't forget, NESQIP is a retrospective chart review on what is written in charts, so and the data are extracted every 3 months. So we need to also consider the quality of data we have.
And there are challenges with PQIP for that reason, because it is a very large data set. So many centres, and it's a very biased selection. Malcolm, I'm ignoring clearly because he's waving his arm.
Obviously, right? Obviously, that happens all the time. And right, okay. So I am still unsure about the delay of surgery because of prehab. What I want the experts in the room to think of is, what does the definition of fit for surgery mean? Because if we don't know what we're working towards, we don't know what we're delaying for. So is the consensus statement or the Delphi going to come up with a definition of what fitness for surgery actually means?
No. I suspect not. I think we might struggle with that.
I think I agree. Prehab helps to put on a table objective data what the physical fitness, nutritional fitness, mental fitness of a patient is. But I think the purpose of a pre-op assessment, and here we're moving forward from assessment to intervention, is try to correct what is modifiable. So I think it's a good moment to correct what we could correct and maybe change that risk factors or attenuate that risk factor before surgery. So maybe you correct one thing and you don't correct the other one. But then again, to be provocative, why do we see patients and if we ignore those information, we don't do anything with those information, or try at least.
Is your question around, do you think we should be looking at, you have to have a threshold, unless you reach this threshold of your peak oxygen consumption as more than 15 or your OT is 10? Or is the question more about, we have to become a bit more accurate and better in conversations with patients about saying, well, at this moment in time, we would estimate your risks could be this. However, we could put you through a 4 or 6 week program. We'll review how you are. Obviously, depends what type of surgery it is and lots of other factors. But then that's kind of letting the patient be involved in that fit for surgery conversation. You're not saying, you're bulletproof, only the surgeon can make a hole in your aorta or something, and that's it, otherwise you'll survive. You're having a conversation about a shift in risk profile. And that's a slightly different way of looking at it, I think.
Yeah, I think it's not a risk threshold. It's a conversation with the patient. That's why it's a shared decision-making process if the patient would like to delay their surgery. It's a risk-benefit discussion, I think. And one patient's fitness for surgery might not be someone else's fitness for surgery.
And for you as surgeons, that needs time. In clinic or wherever you're seeing these people, and for us in whatever clinics we're doing, you do have to have enough time to not have to rush those conversations, because they are difficult to have sometimes, aren't they?
Yeah. And not everybody has it, not all patients. I mean, the patient's the expert about what's important to them. And that's the bit that I think we're bad at with shared decision making. We're all very good at sharing our data with them and our views on the risks and benefits for them. But at the end of the day, it's what's important to them as well has to be taken into account. And there's a patient has a risk, but then you can't also take that into account without knowing what the procedure is, because it's totally different for an esophagectomy than for an inguinal hernia, which is why it's so difficult to come up with a perfect individualised risk predictor for everybody. There's a question in the room.
Hi, thank you. Thanks for an interesting session. There was a question that came and went on the screen that I'm not sure was answered, and it was the one I was looking forward to hearing about, because it's something that I worry about, and that is what to do when a patient doesn't engage with the prehab that they've been asked to do. We had a very high-risk patient for a fever a few months ago who was told that he really needs to have prehab to safely proceed. He was called in excess of 15 times by the prehab team over a period of months while his graft was being made in Australia. Didn't come to any of our classes, somehow got to the day of surgery, and there I met him in the morning, very high risk, was very concerned, spoke to the surgeons, explained my concerns about whether he had any complications he was very likely to fail to rescue post-op, was convinced into doing him because of various reasons, like they thought he was imminently going to rupture. We proceeded, case went well, then he had a post-op bleed, failed to rescue, spent months in intensive care with a trachea. Has been playing a lot on my mind. I've presented it at the M&M. Lots of divided opinion about whether we should have proceeded or not, and I'm interested to know what the panel think about this and similar stories.
Thank you. Good question. So, Heather, as a vascular surgeon, let's start with you.
Well, surgical answer, Heather.
Thank you for that. Yeah. I think it's hard for me not to dodge the question a little bit, because technically before patients undergoing FEVAR should have a 2-year life expectancy. So they shouldn't be so extremely frail that without prehab, if prehab was going to make it or break it for this patient, then they probably shouldn't have been undergoing this surgery to begin with, which is a decision to go backwards, hence my deferring of maybe it should have happened before the prehab. Because I'm not sure I don't think we're at the stage with the evidence for prehab, especially in aortic surgery, which I'll talk about tomorrow, that you could deny someone care because they didn't partake in prehab. We certainly don't have enough evidence for the strength of prehab at this point in time to say, it's so beneficial that if you don't do it, I'm not going to treat you. We're certainly not there yet. So if he didn't partake, and vascular patients are a very special population, it's very clear delaying is not going to then make him partake. You've made the decision to order a $50,000 graft or 25,000 pound graft to put into this patient. Why would you delay at that point? What are you gaining? But that's very specific to that example. But I think it's a little bit like smoking cessation. You can't not treat someone just because they chose not to quit smoking.
I mean, that's going back to with orthopaedic surgery that some areas of the UK had in place a little while ago. If your BMI was more than 30 or you smoked, you couldn't have your knee or hip replacement. And there were lots of areas of the country, I think, that were implementing that. And the scenario you described starts to feel at this stage a little bit like that. So it is really difficult.
If you want a surgical answer, you had a fracture and the fracture needed to be fixed. That's just to give you what you want. But one of the things I think is really difficult is that everybody focuses, or there's reasonable data on the short-term implications of complications, surgery that doesn't quite go to plan. And what we have relatively little of is what does that look in the long term, if you spend 3 months in an intensive care, if you have a tracheostomy, because actually, if you had that kind of long-term implication data, and if you put it to patients in the clinic, often the thing that sort of scares them off surgery is a really in-depth discussion about what happens when these things go wrong. How does that look 4 months into an intensive care admission? It's amazing that when you tell them you've got a 1.5%, 2.5%, 3.5% chance of dying, that number doesn't really register because everyone always thinks they're in the 96.5%. But when you tell them they've got a 50% chance of a complication or a 25% chance of spending 3 months in ITU, it's amazing how their decision-making changes. But we've got really good data on mortality that can be adjusted for numerous confounding factors, but don't really have great data on how those outcomes look in the long term, which probably would have, potentially helped you in your case.
Another interesting point around that is with the increasing kind of emphasis on value-based healthcare provision, as clinicians, do we need to be a bit more accountable looking around at the health economics of the decisions we're making? So in that incident, if Heather has a 50,000 Canadian dollar stent sitting waiting to be put in an 87-year-old person who might otherwise have a 2-year life expectancy, is that good health economics in your surgical decision making? So I'll throw that back to you, because we are actually reasonably good at predictive modelling as to how long people will live. We've got millions of data sets from government actuarial tables. We know what risk factors change life expectancy. So we can, aside from the risk of surgery, look at life expectancy for different diseases, different cancers. And should we be better at that?
And we do it for drugs in the UK. With new drugs have to go through that, through NICE. But it appears new surgical procedures don't go through the same process, particularly robots and things that are very expensive.
I mean, there are nice guidelines for EVAR versus open, and they do for sure go through access. I think you're asking a very slippery slope. It's not necessarily...
It was deliberate.
The clinician... Is it the clinician to start making ethical calls? Because this is something, for instance, that I see probably more than most surgeons as a vascular surgeon, is patients are very clear on what they want until they're actively dying. So you have a long discussion with a patient in your clinic, you decide you're not going to fix their aneurysm, and then they come into the emergency room ruptured, and they very clearly demand surgery, as does their family. What do you do there? Are you allowed to say, well, you know what, a month ago we said no, so sorry. That becomes a very ethical question that I don't think the individual clinician can just start deciding to decline care. It has to be a systems level approach. But it's the same with prehab. That's why I mention it, is patients may have a very clear idea of what they want, and then as soon as they're faced with a different reality, it changes.
I agree. I don't think it's one physician's call. This is a multidisciplinary call, but it's different if I have a patient who comes to prehab with a clear idea of what's coming next. The surgeon's sent to me because I'm having surgery, but by the way, I'm to a higher risk, versus your risk is too high right now. I'm not sure if I can operate on you. Let's see if we can try to modify the risk through prehab, and then let's re-talk at the end and see if surgery is the right decision. So I think it's also creating expectations in patients who are coming to prehab clinic. Because if they come with this mindset, they might be more motivated if they accept to prehab. But if they come already with the clear expectations, I'm going to have surgery, they want to have surgery, they're going to get very upset if you say, after 4 weeks, no surgery. So I think it's really how you initiate this pathway and how they arrive to this program. And but I mean, you can't force anyone to do prehab, but you can ethically say, sorry, the risk is too high. Otherwise, there is a fracture. I need to fix it. And
I think Ross wants to say something.
Yeah, I hope this doesn't sound too cynical, but I think that this is a really interesting phenomenon that we all get into at these conferences, where we love teasing out the minutiae of some incredibly rare, objectively clinical and ethical conundrum. But I think we need to remember that really the gold is on getting the patients prehabbing from the time they're booked
until they turn up to the clinic. And that's where there isn't any dispute about that. And we shouldn't take our eye off the ball, that that's where the real easy money is and the low-hanging fruit and all those cliches. Much as, I know we struggle with this as well, and the surgeons keep on coming up with fractures that need to be fixed for the most ridiculous reasons, and you tear your hair out about it. But systemically, we should be focusing on the easy stuff that we can just say, look, in that 4 weeks while they're waiting, let's get the prehab underway for everybody.
From memory, with the fracture thing, they used to delay surgery if they needed CPR.
Yeah.
Only temporarily.
There will be no bleeding. That is
remediable risk factor.
But I think we definitely need to be conscious about money. I mean, the NHS is a very financially constrained times. We're going into down a slippery slope. I think with complex cancer, what we do we justify doing a £100,000 operation in someone who's 70 and has a massive tumour? Probably not. And you can document it. And if they come in perforated, you can say, actually, we've had this discussion before. We're not going to do anything now. And the family has buy-in. And I think this is translatable to vascular and esophageal and everything else. I would definitely not make a decision just because people are forcing you into one.
Yeah.
It also raises the issue that I think you made earlier on, Denny, which is that if you capture people very early in that pathway, so the endoscopy being a prime example, so in pancreatic it's 90%, in OG it's 75% of these people are never going to come to surgery. If you approach them at endoscopy and if you say, we've got this great intervention, we all really believe in it, this is going to make you feel better, and then a week later their scan shows they've got metastatic disease, and you then withdraw that intervention, that's massively psychologically damaging to that person. So it does raise huge issues, many of which are resource-based. If you're going to approach these people early, that's fine, but you are then somewhat obliged to follow that through and then potentially deliver the intervention through palliative treatment as well as curative. And then before you know, you get into quite a controversial area where I suspect if you ask the room, you'd have 50-50 splits of hands about where the resources are best managed. I don't know the answer to that, but you can, in trying to do a good thing, you can end up in quite a sticky decision making.
It is really challenging. So the prehab program where we are, which is 4 weeks, a month pre-op and a month post-op, because it's prehab to rehab, it's £400 on average per patient. So, a £25,000 draft on someone who has a shorter life expectancy. It is difficult to weigh up these decisions, and we have to only look at the patient in front of us because that's our Hippocratic oath. But I sometimes wonder that we do spend a lot on fixing things that we haven't prevented as well.
Hi. Just speaking to those patients who are maybe in rehab because they're too high risk, and the intention is to lower that risk to get them fit for surgery. Even if those patients don't make that threshold in the end, that can still be a really good outcome, because there's the opportunity in two ways, and we've had examples of this in our practice. One is that they do get fitter, so they might get fitter and weller, but not quite get there and not be considered well enough for surgery. But then they go into the next phase of their treatment in a better stage, and that's a good outcome. And also, we've worked with patients where we've used that opportunity with them to talk to them about what is the best treatment for their cancer and what are the risks, and have that longer, more drawn out conversation about how best to go forward. And so they arrive at that point quite well adjusted to what might come next. So thinking about it as pass-fail or as surgery, not surgery, is a bit black and white. There's opportunities to have other different good outcomes from it.
Sandy, did you want to comment on your experience with the palliative pathway, just as a...
Yeah, thanks, Denny. So I feel very strongly that patients that are on a palliative pathway, particularly if they've had, like you say, they've been built up to say that they're having surgery and we're going to support them through the pathway as we do for prehab, and that's what our teams say, then you dump them because they're not surgical candidates. So I think it's a different form, it's personalised care, but we should still be doing the same interventions and giving patients the same support. And I say that with experience because we had a significant number of end-of-life patients on our SafeFit trial. That's self-referral, and all of them lived beyond their so-called prognostic day, and they got to see grandchildren and their kids' weddings. So I'm not sure that we can just say
it's not the right thing to do, because we already know we reduced admissions, readmissions, GP visits, etc., etc. So there is a balance there of return on investment, and it's actually huge, because I'll talk about it tomorrow. But the return on investment for palliative patients is potentially going to be higher than it is on the surgical population. And the other thing to say, when I've got the mic, is I'm not sure we can talk about responders and non-responders with any evidence or any credibility, because what is a responder? And if you don't respond to increasing your AT or your VO2P, what about if you improve your mitochondria? And aren't mitochondria really important in surviving surgery? And what about if you don't increase or decrease your weight? So I think if we're going to talk about responders and non-responders, we need a consensus Delphi process probably to look at what we believe is a responder and non-responder. And it's clearly important, because if there's also some synergy between tumour outcomes and responding to prehab interventions, then that's really key. Thank you.
Thank you, Sandy. Well, I think you've neatly got us to 4:40, which is the end of this session. So I want to say thank you to the panel for a great session.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.